We are live now.
We are starting with embryology topic and then going to immunology topic because immunology
Okay.
is very big. That's why.
Sure. Okay, one. Yeah. Shall we start?
Yeah.
Yeah. On behalf of Tapisar and President Dr. Sharat Sir and Dr. Radha Vembu, it's my pleasure to invite the speakers for the day for this journal club. And I thank the Salem team for joining the Tapisar. And I welcome the chairpersons, Dr. Vidya Prabhakar, Dr. Kritika, the speaker, and Vani Pujari, the expert for the clinical topic, and Dr. Pramya and Dr. Madhumita, and the expert, Dr. Balakumaran, for the embryological topic. We are going to be, the first topic will be on IVF versus the ICSI, and I would request the chairperson, Dr. Pramya, to introduce the speaker, Madhumita. Over to Dr. Pramya.
Is Pramya there?
I'm calling her, ma'am.
Okay.
Ma'am, she's joining. Ma'am, she's joining now, it seems, ma'am.
Okay.
So, Pramya ma'am, Dr. Pramya Nanjudan is the clinical director of Taran Women's Center, Women's Care and Fertility Center in Salem. Ma'am's done her MBBS in Stanley Medical College and OG from PGI Chandigarh, and she was a senior resident in JIPMER, and she's done her fellowship in reproductive medicine in Women's Center, Coimbatore. She's had about 12 international publications. We'll just wait for ma'am to join to.
We'll start introducing Madhu as
Okay, ma'am.
Pramya has joined. Pramya's joined.
Good evening, ma'am.
Yeah, Pramya. So you can introduce the expert and Dr. Madhu, Pramya.
Yes, ma'am. I invite Dr. Balakumaran, who's the ASRM certified embryologist who's done MS Biotech, MCA, and diploma in PGT and PhD. He's the IVF lab director and the senior embryologist of Kaveri Hospitals, Chennai. And he's a member of IFS, ISAR, ASRM, HRA, and AC, and faculty in national and international conferences. And he has got published 4 articles in various national journals. And his area of interest specifically are male infertility, reproductive genetics, and cryobiology. Welcome you, sir. So here we call upon the speaker, Dr. Madhu, and who is very well known to everyone of us who doesn't need any introduction. Ma'am, is it okay? Can we proceed?
Yeah.
So the topic given by Madhu is like IVF versus ICSI in patients with severe male factor infertility, which is a randomized clinical trial. Madhu, all of us know very well that she is the secretary of Salem chapter of ISAR, and she is EC member of OGSOS, and she is Nanda ISAR Young Youth Brigade council member, as well as peer review for Joggy Journals, and she is the editor of official newsletter of Midlife Management Committee Foxy and publication in charge of Awareness Committee Foxy, and editor of official e-journal of OGSOS, assistant coordinator for online ART course of ACRM 2021, as well as she has won the prestigious Foxy Talent Award, South Zone Coordinator. Welcome you, Madhu, and she has got various awards to her credentials for academics as well as other extraordinary performances. Over to you, Madhu.
Madhu ma'am, you can kindly share your screen.
Karthi, can you stop sharing the screen? You cannot share your screen when someone else is sharing.
Yes, ma'am, I have stopped.
Okay. Again, I'm getting you cannot share while another participant is sharing. I'm getting that. Just check. It is not stopped. No, the screen is still there.
It's stopped, ma'am.
And I'm again getting you cannot share while someone else is sharing. It's coming that.
Kritika was sharing, no? She is stopped.
Kritika, you have stopped. Huh?
I have stopped sharing, ma'am.
I'm again getting you cannot share screen while another
You want to leave
participant.
and rejoin, ma'am, just once? Because for us, the screen is not shared here.
I'm able to see that welcome screen.
We are not able to see it, ma'am.
Okay, you're not able to see the welcome screen. Just a minute.
Yeah.
Okay.
Ma'am, I have made you co-host. Once again, try, ma'am.
Yes, Madhu. Madhu, we can see.
So my screen is visible, ma'am, full screen?
Yes.
Yes.
Yes. Okay. So at the outset, I would like to thank Tapisar, team Dr. Sharad Bhatina, Dr. Radha Vembu ma'am, Dr. Kundavi ma'am, and Dr. Vani ma'am and Sindhuja for bringing us this journal club meet and also for the opportunity today. So today I'll be talking about. Is my next slide seen?
No, it's not coming.
No, ma'am. Just click with your mouse, ma'am.
Just
No
click
laptop,
on
no mouse. Why the next? Why the next?
You can stop sharing and reshare, ma'am. Or you can either click with mouse or arrow mark, ma'am. One should work.
One. No, it was,
Otherwise, we'll start with Kritika.
yes, ma'am. This see. Now it is seen.
Yeah.
Okay. So,
Yeah.
and today, the topic today, the paper that will be presenting is a randomized clinical trial. And it is on the conventional IVF versus ICSI for patients without severe male factor infertility. That is, this severe male factor infertility, they have taken as 2 million total motile sperm count on the day of oocyte retrieval. So for these patients, they have compared conventional IVF versus ICSI. So it was done by Bernstein et al. And it was published recently in Nature and in the journal Nature Medicine in April 2025. And it is a multicentric study which included 6 public fertility clinics at Denmark. And the primary objective was to compare the cumulative live birth rates. That is the cumulative, meaning the one cycle of oocyte retrieval was done, and the transfers of all the embryos formed in that one cycle. So the live birth rate from all these embryos was considered, and this was taken as the primary outcome for comparing ICSI and conventional IVF. And here it is an open label, that is none of the either the researchers or the patients, none of them were blinded, and it is a multicentric randomized control trial. And here, coming to a little bit of background, ICSI came into place after the first ICSI baby was born after around 13 years after the first baby after natural cycle IVF was born. That is, Louis Brown was born in 1978. After that, it took 13 years, and the first ICSI baby was born in 1991. And coming to the timeline of ICSI, the first ICSI was first developed in Brussels by Dr. Palermo, and the first embryo after ICSI was formed in 1990. And The first pregnancy was achieved in 1991, and the first successful ICSI birth happened in 1992. And since then, there is numerous techniques, and ICSI has been perfected and utilized mainly when there is a male factor infertility. So ICSI was first, initially it came into place to address the male factor infertility, and in overcoming the fertilization barriers and in improving fertilization rates, and also as the sole insemination method to be used when surgically retrieved spermatozoa is used. So in this study, the recruitment of the patients happened between November 2019 to December 2022. Out of the total 1,103 eligible women, 824 were taken for the study. And here the patients were taken only when the sperm count was more than 2 million progressively motile spermatozoa on the day of oocyte retrieval. And they were randomized either to the ICSI group or the conventional IVF group. And data collection was completed in December 2023, and the outcomes were followed up. And here, the inclusion included the patients who the age of the women was between 18 to 42, and consent was obtained. And the semen sample, as discussed, more than 2 million progressive motile spermatozoa after density gradient centrifugation. And here, both couples and also single women who are using donor sperm are also included. The BMI of the women considered were between 18 to 35, and also only the first treatment cycle was considered, and any of the factors, that is tubal factor infertility, unexplained infertility, PCOS, and also mild to moderate decreased semen quality in the male factor. So these were the patients who were taken for this study, and patients who didn't refuse to give consent were excluded, and in whom the women had significant morbidity like ovarian cysts more than 4 centimeters, no liver or kidney disease, and uncontrolled thyroid disease, and also women with endometriosis stage 3 or 4 hypo, and women with other severe morbidity like diabetes or CVD, they were excluded. Women who underwent previous IVF or ICSI treatments with the current partner were excluded. Women who didn't speak the native language, and also women who used donor oocytes or in whom frozen oocytes were used. So these were the women who were excluded. So out of the total more than 1,000 eligible women, around 824 were taken for the study, and then they were randomized to either conventional IVF and ICSI. And out of that, finally, the number analyzed were in the conventional IVF 378, and in the ICSI group it was 388. For some around 20 couples who were randomized to the conventional IVF group, on the day of oocyte retrieval, they were found to have, unexpectedly, they were found to have the total motile sperm count after centrifugation to be found to be less than 2 million. So they were shifted to the ICSI group. So here, the routine control ovarian stimulation was done, and TVS under transvaginal scan, the monitoring was done, the trigger was given, and then insemination was done either using, according to the randomization, embryo was cultured, and with luteal phase support, embryo transfer, and cryopreservation of the excess embryos was done. And as I mentioned, if the progressively motile spermatozoa was unexpectedly less than 2 million on the day of retrieval, ICSI was done. And all these women underwent single blastocyst transfer, preferably on day 5. Very few who with less than 4 oocytes retrieved, transfer on day 2 or 3 was done. And the excess blastocysts, they were frozen, and FET was done on a later date if the first cycle was negative. And for none of them, PGTA was done. And serum pregnancy test was done around 11 to 16 days after embryo transfer. And the transvaginal scan was done to confirm the ongoing pregnancy rates between 7 to 9 weeks. And the standard clinical care throughout pregnancy and neonatal period was done. And the statistical analysis, this study was designed as a superiority study comparing conventional IVF and ICSI with an 80% power, and 5% was the significance level that was taken for this for the two-sided test. And the aim was to detect at least a 10-point difference in the cumulative live birth rate. And coming to the outcomes, the primary outcome was the cumulative live birth rate, which was defined as at least 1 live birth after completing of the ART cycle. This included not just the initial fresh TT, but all the subsequent FETs from that cycle. The follow-up period was 12 months after the inclusion of the last participant, and live birth rate here was defined as the delivery at or beyond 22 weeks of gestation. So this was the period cutoff taken. And secondary outcomes, it included various factors, including live birth rate after the first embryo transfer itself. So here, the key aspects of this study were they targeted the first cycle patients, that is women undergoing the first cycle of IVF or ICSI, and blastocyst transfers were emphasized with more than 96% being blastocyst transfers. They were all elective single embryo transfers, and the cumulative live birth rate was taken as the primary outcome measure. So here, when comparing the primary outcome, the cumulative live birth rate was around 43.2% in the ICSI group, whereas it was around 47.3% in the conventional IVF group, and the p-value was not statistically significant, though the conventional IVF group showed a marginal increase in the cumulative live birth rate. So again, out of the total, in total, around 26% of the women in the ICSI group got pregnant in the first transfer itself, whereas it was 31.6% in the conventional IVF group, and this difference was statistically significant. And here, various other secondary outcomes were also considered, like the implantation rates and also the ongoing pregnancy rates, the miscarriage rates, ectopic rates, the stillborn rates, the incidence of twin pregnancy rates. So all this were taken as a secondary parameters, but none of this showed any statistical difference. So the fertilization rates per oocyte retrieved was substantially less in the ICSI group when compared to the conventional IVF group, where it was 53.5% in the ICSI group, whereas it was 58.1% in the conventional IVF group, and this was significant. The total fertilization failure, again, it was around 4.8 in the ICSI group and around 3.7 in the IVF group, and the time to viable pregnancy, that is leading to live birth, did not differ between both the groups. It was around 90 days in ICSI group, and in IVF it was around 93 days. And again, the time taken for 25% of the population to achieve a live birth was also almost similar in both the groups. So here, important factor with a statistically significant difference was the fertilization rate per oocyte retrieved. It was around 53.5% in the ICSI group, whereas it was 58% in the IVF group. So other factors like the cumulative embryo transfer cycles, it was almost the same, that is 580 in the ICSI group and around 593 in the IVF group, and other factors, total number of cycles and transfer cycles were all, and ongoing pregnancy rates were almost similar. So the secondary analysis also showed that in women with less than 32 years old, conventional IVF was definitely better for these women, and also in women who showed a normal ovarian response, that is when in cases where 10 to 15 oocytes were retrieved, in these cases also definitely conventional IVF has an edge over ICSI. And other factors like male factors like sperm morphology, normal sperm parameters, treatment indication, AMH levels, and the center where the trial was done, these had no effect on the primary outcome. And there was also no difference in the two groups in obstetric and perinatal outcomes. Like there's no difference in GDM, preeclampsia, and also the mode of birth, and also in case of the birth weight also of the baby. So here, one concern that was brought up in this study was that the ICSI is prone to cause oocyte damage, which can occur during the denervation stage, during the ICSI injection itself, or during the later assessment of the embryos. So again here, because there's always is, in spite of numerous studies showing otherwise, and numerous studies also showing that there are these conflicting findings that show that that show some association of ICSI with increased risk of congenital malformations, and also some certain specific malformations also. So this debate is always there regarding this neurodevelopmental disorders and also cancers. So it was concluded here that ICSI does not improve cumulative live birth rate when compared to conventional IVF. And conventional IVF is the preferred first-line treatment for patients with normal or non-severely decreased sperm quality. And ICSI should be reserved only for patients with severe male factor infertility. Conventional IVF is safe both for the oocytes and the sperm. It is more cost efficient and resource efficient also. And any method, the most effective and least invasive method should be prioritized. And in the secondary analysis, also it showed that there was no difference in using either the fresh semen sample or the cryopreserved sperms here. It showed no effects on the cumulative live birth rate. There was no increased risk of total fertilization failure after conventional IVF. And ICSI did not show a benefit over IVF in women with unexplained infertility also. And this study did not show any increased risk of congenital malformations in either of the groups. In case of, and also there was no difference in the gender, perinatal and obstetric outcomes also. So here, coming to the strengths of the study, this is a multi-center RCT design with a good participation cohort. None of the patients were lost to follow for the primary outcome. The focus was on the first cycle and also which reduced substantially the inclusion bias also. And the use of the cumulative live birth rate was used. So because all the transfers were taken, so there was no bias regarding the embryo selection. And all embryo transfers here were single embryo transfers. And more than 96% were blastocyst transfers. But then again, this study here, the participants underwent randomization even before the oocyte retrieval. So there was no blinding also. So there is this, because there was no blinding, there is this slightly concern of introduction of the performance bias. And here actually initially when the study was started, the normal sperm morphology more than 4% was only considered to be taken. But then again, once it started, it was amended because there were a lot of inconsistencies in the diagnostic samples across the fertility clinics. So again, this was it was amended, and sperm morphology was not considered for this study. It was only the total motile sperm count that was considered. So coming to a few similar studies, this was a study that was done in Vietnam, and it was published in Lancet in 2024. Here, it was done, here again, ICSI and conventional IVF was considered in couples with non-severe male factor infertility. Again, this was a similar multi-center trial. It was again non-blinded and RCT. The difference was that in this study, the sperm parameters that were taken were between 5 to 15 million per ml. And also the sperm motility that was considered for this study was between 10 to 32%. So only these patients were taken for the study. And it was concluded that in couples with infertility with non-severe male factor, ICSI did not improve the live birth rate when compared to conventional IVF. And because ICSI is again an invasive procedure with additional costs and also the potential increased risk to the offspring health, the routine use is not recommended. Again, this was another study, another RCT, which was done and published in Lancet in 2021, done in China. This included a large population with almost 3,000 patients. And only the couples with the male partner having a normal sperm count according to WHO 2010, the classification were taken. And in this, again, it showed that ICSI did not improve the live birth rates when compared to conventional IVF. So what does Cochrane say? Cochrane in 2023 concluded that the current available studies that compare ICSI and conventional IVF in couples with males presenting with a normal total sperm count and motility showed that neither method was superior to the other. Neither conventional IVF or ICSI was superior to the other in achieving live birth rate, clinical pregnancy, or also in giving us a viable intrauterine pregnancy. So with this, thank you once again for the opportunity, ma'am.
Thank you, ma'am. I request
I'll stop sharing.
Balakumran sir to add his comments, please.
Yes, good evening, one and all present here. Ma'am, actually, you explained very clear. Actually, Sindhu has shared this journal by Monday to me. I was fighting with it because it has a lot of data and it has a huge population, and this is a kind of, as you said, it has strength and limitations in this study. And interestingly, actually, we will be worried, and especially our clinicians will be worried about fertilization rate when we are approaching for a conventional IVF. But this study has shown that fertilization rate is significantly different from the ICSI procedure. But as this journal has prepared as data with non-severely male factor. Actually, in this study, there is a statement mentioned is like the fertilization rate from the M2 M2 sites. That is only we can see in the ICSI procedure, not in the IVF procedure. So we have to consider that also. And more than normal morphology, like 4% morphology is like it's not considered. And with all this, actually, till it is a debatable, we can't come to the conclusion. Either we have to go with the conventional IVF or ICSI. But nowadays we are like turning our procedures from the ICSI for all to conventional IVF for this kind of sperm parameters. So we can consider this. And I have a one question from you, ma'am. As a clinician, and you are seeing a day-to-day practice, and you are practicing with infertility. So, what is your opinion about selecting the procedures, like either it is a IVF or conventional IVF or ICSI? Depends on the semen parameters, ma'am.
Sir, though the studies are showing that conventional IVF should be used, I think since last I think 8 years that I'm practicing infertility, it's been purely only ICSI, sir. Nowhere
Yeah, that's what,
putting
ma'am.
purely
Actually,
ICSI.
even in
But
all
then
conference, it is debatable nowadays. But some of the like faculties in even in a national conference, international conference, and all, they are showing their own data, which they worked with conventional IVF and also ICSI. Even they are saying like they didn't have any much significant difference in blastocyst rate or live birth rate also. But since uh, from this journal, actually, we can consider only non-severe male factors, but we don't have an idea about what is the role of morphology or role of DFI and all those things. Nowadays, it's a booming like. So we have to think about it. But with all this, even if it is a huge data and it is a randomized control study, but we can't go with this. But the only happy thing is that, interestingly, I was happy when I'm reading this paper, is a fertilization rate is something giving a positive note when we are thinking about conventional IVF.
yes.
So I would like to ask our chairperson, Dr. Vani, ma'am. So you are a very senior person. You are seeing so many patients, ma'am. So what is your opinion, ma'am, regarding the sperm parameters? How will you go with this selection of procedures, ma'am?
Two things. One is Pramya is the chairperson. The second
Ma'am,
Oh, sorry, ma'am.
I do
Sorry.
have, no. I do have a few things to say about this. I will reserve. I think Dr. Ramaraju sir wants to say something.
Yes,
Yes,
yes.
yes.
Sir has put in a chat box about
What's the duration of married life in this group?
so that data they've not given in this
Not
study at
mentioned.
all.
Because
Nowhere they've mentioned that, sir.
So if you Google the age of marriage in Danish group, it's 39, 38 years.
Mm.
So then at 38 years, what's the mean number of oocytes we get?
Quite less, probably in European population, maybe
Better there, maybe.
better than us, but still less.
But there is an AFC percentile is also already there. So that is one thing they did not mention.
Okay.
The second thing is they never said 2 million count. 2 million progressive motile sperm.
Yeah.
Progressive model, yes.
That's a camouflage.
Yeah.
Meaning, sir?
That's not the actual count.
It's not actual count.
Okay.
The 2 million motile sperms after double density gradient centrifugation on the day of oocyte retrieval.
Then how can it be male factor?
Manufacturer,
Sometimes you
yes.
can get a poor yield. That's the second
The
thing.
study was for
Non-severe mean factor.
Non-severe manufacturer.
Then
Not
define
severe.
what is male factor.
They didn't mention it.
And
This is
second
the
thing,
criteria that they have taken.
no,
Yes.
you can't take whatever criteria you want. No, you have the WHO guidelines, and the previous one of the paper showed 210 guidelines followed. One of the review paper. You can't take whatever you want. You have to take the current one in relation to the year it was published.
Mm.
Then you have the in the current WHO manual, you have the percentile distribution of count, motility, morphology from time to conception within a year.
okay.
Then it's not falling into that level. When you leave off morphology 4%, then is it true male factor we are speaking about? That's my opinion. I'm not questioning the paper, but I'm just pointing out the flaws. You can't just say, that means in the middle of the study, the protocol was changed.
Yes, sir.
Yes, sir. It was changed.
And second thing is there's no external validation of the quality of the analysis.
Yes, sir.
Yes, sir.
And on the day of the, is it the diagnosis at the time of the entry of the patient or on the day of the egg pickup? On the day of the egg pickup, you can have a variety of sperm parameters in terms of count and motility.
But on the day of the procedure only they did, sir.
They did.
Yeah.
And those are my, the paper is nice, but those are my reservations of comments on the paper.
So what is your opinion about IVF ICSI, sir?
When it does not fit the criteria, then second thing is rescue ICSI was not done. Why was it not done?
Yes, sir. They've not mentioned
Not
about.
mentioned, sir.
Or is it all of them are insurance patients where they pay only for IVF?
Mm.
This is a public sector hospital, so everything is from the government.
You can't take it in Germany. If the patient gave a consent for IVF, only IVF is done. You can't do ICSI without the patient's consent. What appears apparently, second thing is, it's not the original nature, but nature has a lot of sister journals. Nature has a lot of sister journals. The main nature journal and nature communication are not equal in their index impact factor. I mean, my comments are like ICSI for all, nobody knows the answer. But it throws a light that if you have 2 million motile sperms, you can do an IVF, which is less invasive, with a with a very good fertilization rate and a blastocyst rate of 93%. But when it comes to a paid patient, how do you judge it? Do you return the money? These are some of the ethical questions one has to debate also in a paper. Here the flaws are one is duration of married life, removing morphology, and it's the post-processing sample of total motile sperms is the criteria they have taken. They have not taken the pre-diagnosis as a criteria. I mean, sorry for being pessimistic, but I wanted to.
No, sir.
No.
It's very easy to fall into these traps, sir. So you're rightly educating us about what all we should look at.
Yes, sir, definitely.
That way, I mean, the presentation is excellent. The highlights have been excellent. But when you read the journals, and read the letter to the editor. There's nothing wrong in writing to the letter to the editor for this saying that asking for the if morphology is taken away, because last few years there are a lot of papers coming in role of morphology because of the NGS and the proteomics, which are showing causes of morphology. When writing to a letter to the editor is also a good quality publication. I encourage the speaker to write to the letter to the editor asking for this clarification so that it becomes a good paper for her and a citation for her. That's my advice.
Yeah.
But overall, I applaud the initiative of this scientific meeting, because it awakens it up to good scientific practice. Congratulations to everybody.
Thank you very much
Thank
for
you, sir.
joining.
Thank you so much, sir.
Thank you for your words, sir. Definitely valuable.
Good wishes, Amma.
Thank you, sir.
Thank you, sir.
Thank you for your time and comments, sir. Ramya ma'am, you would like to add anything?
I think sir has made a very clarified statement, because at the outset, I think when Madhu mentioned, we all presumed that it must be the basic semen analysis, but it is a post-process and 2 million progressive motility. So when it comes to that criteria, I think otherwise also when you take a normal semen sample and process, you are going to get that much only. And ICSI for all is still a question. And for our populations, because of the economy practiced in various cities according to their level of economy, we can't make a patient to choose for an IVF or ICSI, because I think for our clients, they still depend on us. What is right, you do it. Unless until maybe in the cities or the higher end where they make a choice like, yeah, do this way or do that way. So I think still we are practicing ICSI. If we take a criteria like 38 years where the number of oocytes is retrieved is like on average, where the AFC percentile is mentioned, considering both the factors, I think still practically, I think it is ICSI, because we are not funding. It is being funded by the patient. We can't say for a failed fertilizations, and we can't give explanations for a rescue ICSI. I'm speaking practically, I'm not speaking like as per the literature or something like that. But at the outset, when we are doing ICSI, again, lower fertilize, I mean, in the sense like day 3 embryos, we don't get a good number of day 3 embryos as a storage, as well as cumulative live birth rate comes down because we are injecting the sperm into the oocyte. So probably there might be a possibility of the aneuploidies getting undetected unless until you're not going to do a PGTA. Whereas in conventional, there is a possibility that the embryos gets deselected and doesn't get fertilized or grow or does not reach the blastocyst stage. So here there is a possibility that number of transfers might get increased, or else there might be a possibility of aneuploidy embryos getting transferred if you're not considering a PGTA. So considering all the facts, I would still say like, if you get a good population where they do understand about this IVF ICSI and make a choice, yeah, fine. Otherwise, I think ICSI should go.
Thank you, ma'am. Actually, my perspective, I mean, I don't have very vast experience, but in my perspective, in the last 1 year, actually, my perspective has changed about IVF, because when patients have DOR and there is a reasonably good sperm count with motility and morphology post-wash, we are trying IVF, and we are having, because like Madam said, the degeneration rate still exists with ICSI, and it can be immature oocytes also sometimes. What happens is when we leave a long incubation IVF, it is helping us with the oocyte maturation, as in it is giving time for the oocyte maturation, and surprisingly, even 2 oocytes, 3 oocytes are giving excellent blast. I'm not saying it will work for everyone, and it is not in all cases, but losing complete hope on IVF is definitely not the thing. This is just my personal experience.
Ma'am, as your
Last 1 year.
experience, are you doing a full IVF or a sibling ICSI and all for this
So
kind of
when
what you are
when it is only 2-3 oocytes,
Yeah.
we have tried full IVF, and when the male factor is good actually, and it has resulted in blast. Of course, we do cumulative, embryo pooling for these patients, but still, it is better than denuding it, seeing 1 GB, 1 M1, and then culturing it, and then doing ICSI, and then causing more trauma. So only in those kinds of cases, we are taking calculated risks, not 100% risk, and after explaining to the patient only.
Yeah.
Ma'am, shall we move to the next session, ma'am?
Sure. Sindhu,
Yes, ma'am.
Vidya is held up, so I'll introduce.
Yes, ma'am. Okay.
So take away my slide.
We welcome Vani ma'am to be the expert for this session, who is the director of Akshaya Fertility Center and Women's Center and president of Salem chapter of Tapisar, and she is a joint treasurer of Tapisar. Kindly introduce the speaker, ma'am.
Kritika's not to come. Her CV is not there.
Sahiti
Kritika's CV is not there.
is there, ma'am. It's there. Kritika ma'am, can you stop sharing 1 minute, please?
I am sharing, ma'am.
Okay.
Kritika is a consultant at PRN Multi-Specialty Hospital, Salem. UG PG from Amrita Institute of Medical Sciences, Kochi, University gold medalist. She's did her, I think, fellowship from Chettinad Medical University, and she's a former faculty at Vinayaka Mission Medical College and Akshaya Fertility and Apollo Hospitals, Chennai. She's treasurer of Salem chapter of Tapisar, and she was with me for quite some time, and she is a dear friend of mine. Please, Kritika.
Tell them this message.
Ma'am, it says that your screen sharing is paused.
No, ma'am. Retry once again.
Okay.
Yeah.
Not coming, Kritika.
Yes, ma'am, I'm trying.
Check. Okay. Can the technical people help her out?
Wait, 1 second, bro. Ma'am, do you want to send the presentation and I'll try sharing?
Yes, I'll do that. Is it seen now, ma'am? No.
No, ma'am, we can see only the blank screen.
Okay.
Yes.
Can you go back and try once more?
Hello. Check.
Yes, ma'am, we can
Yes,
see
ma'am.
the slides.
Okay.
Yeah.
Good evening, one and all. I thank the Tapisar team to give this opportunity. Today, we'll be discussing about this article, exploring the immunological aspects and treatment of RPR and RAF. But since it is a very huge article, I'll be discussing only the immunological aspects, and we'll discuss treatment in the next class. Our knowledge about follicular genesis, in vitro embryo culture, and chromosomal composition and endometrial receptivity has increased over the past decades. But nevertheless, a high percentage of embryos, they get lost immediately after implantation or shortly after as clinical miscarriage. So what happens to these embryos? We know that by far, the main contributor of embryo losses are embryonic aneuploidies. The other factors are endometrial factors, hydrosalpinx, infections, immune tolerance to pregnancy. At the same time, owing to repeated failures, even after gamete donation, we have witnessed increased demand for immune tests and immune treatments. So now basics in immunology. We have two types of immunity, innate and adaptive immunity. Innate immunity is the first line of defense, and the response does not involve the antigen presentation.
Kritika, can you go full screen? I think something is disturbing.
Yes, ma'am.
It's okay, then go carry on.
Okay. Innate immunity is the first line of defense, and the response does not involve antigen presentation. It is non-specific, and the cells lack memory. The cells involved in innate immunity are natural killer cells, macrophages, dendritic cells, polymorphonuclear cells, mast cells, and eosinophils. The second type of immunity is adaptive immunity. It requires antigen presentation. It is very specific, and the cells, they have a very targeted action. The cells involved in adaptive immunity are cytotoxic T cells, Th1, Th2, Th17, Treg cells, B cells, and myeloid suppressive cells. First, we'll look about NK cells. The role of immune system in recurrent miscarriages and RAF remains one of the most controversial issues in ART. The maternal tolerance, it begins at the uterine level, and successful adaptation to the semi-allogenic fetus this process is very complicated. The peripheral blood natural killer cells have become an immune steady core for patients with RAF or recurrent miscarriages based on the mistaken notion that they cause reproductive failure by killing or rejecting the embryo. But from immunological point of view, it is an erroneous judgment because peripheral natural killer cells and uterine natural killer cells are completely different. Peripheral NK cells are cytotoxic cells, and they represent the first line of defense against viruses, tumors, and damaged cells, and they are not trained to kill or reject healthy embryos. In peripheral blood NK cells, it represents the heterogeneous populations with various subsets, differing function and surface phenotypes. So the majority of the cells in peripheral blood are CD56 dim cells with CD16 antigen plus. 10% are CD56 bright and CD16 minus. The KIR receptors on the NK cells, it determines the function of the NK cells in context to other ligand receptor interactions. But furthermore, the KIR receptors of uterine natural killer and peripheral NK cells are different when taken from the same women at the same time. Uterine NK cells shows prevalence of CD56 bright and CD16 minus subsets whose activity is influenced by KIR receptors, and they differ absolutely from peripheral blood natural killer cells in phenotype markers and also in functional activity. Uterine NK cells killing function is very weak when compared to peripheral blood natural killer cells. Uterine NK cells acquire their functional properties in utero and are predominant in non-pregnant endometrium, and they increase and change in morphology during secretory phase of the menstrual cycle. In pregnancy, uterine NK cells undergoes adaptation. The KIR receptors, which is present on the uterine NK cells, it binds to the extravillous trophoblast, and uterine NK cells differentiate, proliferate in specialized progesterone-dominated microenvironment and under endometrial-derived interleukin-15. In early pregnancy, uterine NK cells, they infiltrate the trophoblast by controlling the trophoblastic invasion and remodeling of the spiral arteries, which increases the contact area between the maternal blood and the trophoblast. It is a very important process for healthy placenta development. So increase in number of uterine NK cells in the secretory phase of the menstrual cycle and pregnancy is a physiological process which helps in embryo implantation, and it is not a marker of embryo rejection. In pregnancy, decidua has increased number of uterine NK cells, which is CD56 bright and CD16 minus. Successful maternal tolerance to semi-allogenic fetus occurs at the site of placentation. The key to maternal-fetal tolerance process is the remodeling of the spiral arteries with destruction of media by invading extravillous trophoblastic cells. The EVT cells, it expresses class 1 HLA-C and non-classic HLA-G and HLA-E. In EVT cells, HLA-A, B, and class 2 antigens are absent. The maternal and paternal HLA-C types are expressed in high levels at the same time by EVT cells, and they are recognized by the KIR receptors which are present on the uterine NK cells. In any pregnancy, the KIR receptor genotype, it can be either AA, which is non-activating, or AB or BB. This AB and BB are activating KIRs, and AA is a non-activating KIR. HLA-C ligands for the KIRs are divided into two groups, HLA-C1 and HLA-C2. Of these two, C2 is a stronger ligand. HLA-C1 is a ligand for weakly inhibitory KIR2DL2 and KIR2DL3. HLA-C2 is a ligand for KIR2DL1, which is an inhibitory KIR receptor. The haplotypes A, which is non-activating genes for KIR, it increases the risk of pregnancy complications. Haplotype B, which is the activating genes for KIR, it confers protection from the pregnancy disorder. So the invading EVTs, they are the principal site of HLA-C expression in the decidua in both paternal and maternal HLA-C allotypes, which are presented to the KIRs. The placentation is regulated by the interaction between the KIRs, which are present on the uterine NK cells, and HLA-C allele, which are present on the EVT cells. So there is increased risk of miscarriage or implantation failure when the mother has KIR-AA receptor, which is a homozygous haplotype, and fetus, which has more HLA-C2 alleles when compared to the mother, and also when additional HLA-C2 genes are from the paternal origin. So this is the uterine NK cell, and these are the KIR receptors which are present on the uterine NK cells. And these are the EVT cells. The EVT cells has got HLA allele from the mother and also from the father. And if the KIR ligand has got AA haplotype, which is a non-activating KIR, it results in a compromised placentation. If the KIR receptor is either AB or BB, it's got a activating KIR receptors, it results in a correct placentation. So what happens in ART? In ART, it differs from the unassisted pregnancy because the patients often receive more than one embryo per transfer. Donor oocytes, donor sperms, and donor embryos are often used. After double embryo transfer, more than one paternal HLA-C allele is expressed. In oocyte donor cycles, the oocyte maternal HLA-C is genetically different from the maternal receptor, and this donor behaves like a paternal HLA-C. This implies that more than one non-self antigens are presented to the maternal KIR receptors, and moreover, the patients with RIF are subjected to multiple embryo transfers. So the KIR receptors which is present on the mother, it can be either activating, which is AB or BB, or inhibiting signals to the uterine NK cells. KIR-A is inhibitory and KIR-B is activating. And if the mother has got a AA haplotype, so it results in the implantation failures. A study showed significantly reduced live birth rate per cycle after double embryo transfer with the use of donated oocytes was observed in mothers with KIR-AA when compared to those of KIR-AB and BB. And higher pregnancy rate was observed after HLA-C1 donor transfers when compared to unknown HLA donor status. These findings show that the maternal KIR haplotype and fetal HLA-C, they have an impact on the live birth rate after IVF, especially when the donor oocytes and double embryo transfer is done. Therefore, selecting the HLA-C1 among the oocyte or sperm donors for patients who undergo oocyte donation and who exhibit inhibitory KIR haplotypes would be safer. So we are done with the natural killer cells and we'll move on to the macrophages. There are two types of macrophages, M1 and M2 macrophages. Macrophages, they are present in the decidual microenvironment and it can contribute to recurrent pregnancy loss and RAF. So M1 macrophages induces inflammation and M2 macrophages suppresses the inflammation. So M2 macrophages are abundant in the embryo during the luteal phase and also in healthy pregnancy. M1, M2 macrophage ratio imbalance can lead to complications like preeclampsia, IUGR, RPL, and RAF. So in patients with RAF, and the presence of diffuse adenomyosis was associated with marked increase in M1 macrophages in the stroma. Dendritic cells play a crucial role in embryo implantation by regulating the immune response and aiding tissue remodeling. The dendritic cells produces indoleamine dioxygenase. It boosts the number of TREC cells while reducing Th1 cells and the cytotoxic activity of CD8 cells. During implantation, the depletion of dendritic cells was associated with implantation failure. So innate immunity is over and move on to the adaptive immunity. The T cells, the T lymphocytes are a crucial element of adaptive immunity. So there are two types of T cells, T helper and cytotoxic T cells. And they play an essential role in fetal antigen recognition and modulation of local immunity. The percentage of CD8 T cells, which is a cytotoxic T cells in peripheral blood, was higher in women with RPL, and CD4-CD8 ratio was lower in women with RPL. The TREC cells, they are the regulatory T cells. And the markers are CD4, CD25, and FOXP3 plus gene. They have essential roles in the uterus, particularly during the peri-implantation period, and they are associated with the anti-inflammatory transition required for embryo receptivity. The fewer TEC cells were associated with implantation failure, and they had an altered phenotype in RAF and RPL. CD4, CD25, and FOXP3 plus TREC cells, they may serve as a superior pregnancy marker for assessing miscarriage risk in pregnant women. So the balance between the TREC cells and the cytotoxic Th17 cells is crucial for pregnancy outcomes. The patients with unexplained RPL and RAF had higher levels of Th17 cells, and patients with RPL and anti-TPO antibodies showed higher levels of Th17 cells. B cells, the marker for B lymphocytes are CD20. They were increased in endometrium of patients with RPL and RAF. Next one is myeloid suppressor cells. And there are two types of myeloid-derived suppressor cells. One is monocytic myeloid-derived suppressor cells. Another one is polymorphonuclear cells. In healthy pregnant women, both types of MDSCs are increased in the endometrium and peripheral blood. On the contrary, the patients with RAF, they showed significant reductions of both the cells, both myeloid cells in both peripheral blood and also in the endometrium. The cytokines, a diverse group of signaling proteins that play a crucial role in implantation. They are broadly classified into interleukins, interferons, tumor necrosis factors, colony-stimulating factors, chemokines, and growth factors. The type 1 chemokines, that is interferon gamma and TNF-alpha, they are actually, they are not so, it causes reduced implantation. Type 2 cytokines are interleukin 4, 5, 6, and 10. The dysregulation of interleukin network jeopardizes implantation leading to RAF. The overexpression of TNF-alpha, interferon gamma have been observed in RAF. The Th1 type immunity to trophoblast seems to be associated with unexplained pregnancy loss. So we always need a type 2 immunity, which leads to successful pregnancy. High levels of interleukin 1 beta 17, 23 and lower levels of interleukin 10 and TGF beta were observed in the uterine fluids of patients with RAF. Leukemia inhibitor factor, it plays a vital role, and low levels were associated with RAF. So this is the gist of what we have discussed. So RAF and RPL, it's caused by increased NK cells, increased lymphocytes, increased B lymphocytes, reduced myeloid-derived suppressor cells, reduced macrophages, reduced dendritic cells, and altered microbiota, and presence of HLA class 2 cells, and reduced cytokines and immunotolerance loss. So we have explained everything in detail, so I'm not going to this tabulation. So autoimmune diseases and RAF, APS, the presence of antiphospholipid may inhibit the expression of FOXA10 in the endometrium, and it is associated with impaired endometrial receptivity, resulting in RAF. In SLE, the anti-nuclear antibodies, it penetrates the cell membranes and it causes cytotoxic effects and interrupts mitosis and damages embryo quality, resulting in RAF. In celiac disease, the incidence of RPL is double in patients suffering from celiac disease when compared to the healthy populations. In celiac disease, there is always a nutrition deficiency. So there could be zinc, selenium, folic acid deficiency, and the inability of the transglutaminase antibodies, which are present in celiac disease patients. It can target the trophoblastic cells and disrupting the normal function, leading to apoptosis. Thyroid autoimmunity, it is defined by the presence of autoantibodies against thyroid peroxidase or thyroglobulin antibodies is associated with RPL or RAF. Patients who tested positive for anti-thyroglobulin antibodies exhibited significantly lower rates of fertilization and implantation. Medically defined hypothyroidism that occurs before conception or during the early stages of development should be managed with levothyroxine. In women with RPL and subclinical hypothyroidism, TSH should be assessed in early pregnancies, and any identified hypothyroidism should be treated with levothyroxine. Conversely, euthyroid women with thyroid antibodies should not receive levothyroxine treatment. Ma'am, I'm done with immunology.
We can go ahead.
Can continue, ma'am?
Yeah.
Okay.
So we'll finish.
Ma'am, you decide, ma'am. Anything is okay.
Okay. Another 10-15 minutes or so.
Yes, ma'am.
Okay. We'll move on to the immunological treatment of RPL and RAF. Corticosteroids. The first, prednisolone is beneficial for patients with RAF or RPL with high NK cells. In patients with RAF, prednisolone treatment increases the TREG cells and improved Th17 TREG ratio. In one RCT, the fertilization, pregnancy, and implantation rates were significantly higher in patients with RAF and which are positive for ANA treated with the prednisolone 10 mg per day and aspirin 100 mg per day. Low-dose steroids was effective for autoantibodies positive women with RAF. However, steroids did not increase the live birth rate in patients with RAF without autoimmunity. In refractory APLA-related pregnancy loss, using first trimester low-dose prednisolone 10 mg per day along with conventional treatments such as aspirin and heparin may be beneficial. In patients with RAF for positive for anti-ovarian antibodies, prednisolone 0.5 mg per kilogram has been shown to improve implantation, pregnancy rates, and live birth rates. HCQ. HCQ has an antithrombotic, anti-inflammatory, and immunomodulatory properties. Studies have shown that in patients with APS, the addition of HCQ to conventional treatment improved the live birth rates and reduced pregnancy loss. The best rates were obtained when HCQs were given at a dose of 400 mg per day when compared to 200 mg per day, especially the fetal loss more than 10 weeks and placenta-mediated complications were reduced with HCQs when given in these doses. In RAF, HCQs enhance TREG cells and reduces the Th17 cells. The calcineurin inhibitors, these are the group of immunosuppressive agents that specifically inhibit calcium calmodulin dependent phosphatase calcineurin, and it blocks T cell activations, cytotoxicity, B cell growth. Cyclosporin A and tacrolimus or calcineurin inhibitors. Tacrolimus binds to FK binding protein 12 to produce a complex which inhibits calcineurin. Cyclosporin A binds to cyclophilin to generate a complex and which also inhibits calcineurin. These drugs have not been associated with increased risk of birth defects. Cyclosporin, low dose cyclosporin A, 100 mg or 150 mg per day for 30 days to 6 months, which is initiated after a positive pregnancy test. It increased live birth rate in RPL patients and it reduced miscarriage rate. In an RCT, cyclosporin A achieved 77% of live birth rate in RPL patients who did not respond to other therapies such as aspirin, prednisolone, heparin, or LIT. Tacrolimus, the low dose of tacrolimus, 2 to 3 mg per day for 16 days, was administered 2 days prior to ET and was continued for 16 days. It has been found to improve reproductive outcomes in women with RAF and elevated peripheral blood TH1, TH2 cell ratios. Vitamin B with tacrolimus improved clinical pregnancy rate and LBR in patients with high TH1, TH2 cell ratios. Tacrolimus with low molecular weight heparin also improved pregnancy rates in patients with elevated peripheral natural killer cells. Sirolimus, rapamycin, is the mTOR inhibitor and an autophagy inducer. It is a macrolide antibiotic and an immunomodulator. It is a new drug to treat RAF patients with elevated TH17 TREG ratio. So normally, autophagy is involved in endometrium during residualization and trophoblastic invasion. This mTOR can inhibit this autophagy. So sirolimus inhibits this mTOR. The sirolimus enhances the endometrial and macrophage autophagy, thereby reducing the risk of miscarriage. It is given at a dose of 2 mg per day for 17 days in previous cycle of embryo transfer. This agent does not seem to be an absolute contraindication to pregnancy, but we are not sure if it is safe to use in these complex cases of RAF. IVIG, it reduces the activity of NK cells, it increases the activity of TREG cells, blocks anti-HLA antibodies, and prevents complement activation. It is beneficial for patients with increased TH1, TH2 ratios or increased TH17 TREG ratio. It is given at a dose of 0.2 gram per kilogram every 2 to 3 weeks in the first trimester and then monthly till the end of second trimester. In primary RPL, it is started on the day of embryo transfer. In secondary RPL, it can be started after a positive pregnancy test. IVIGs are effective and safe treatment for pregnant patients affected with RPL and SLE or APLA. GCSF can increase interleukin-10 synthesis by the TREG cells and thereby improving endometrial remodeling and receptivity. So it can be given either subcutaneously or intrauterine infusion can be done. It is given at a dose of 300 microgram per 1 ml. The timing, if it is given subcutaneously, it is either given on the day of progesterone start or few studies mention that they have given 1 hour before embryo transfer. When it is given intrauterine infusion, it is given on the day of progesterone start. Few studies suggest that in patients with RAF and endometrium, intrauterine administration, it confers better CPR when compared to the subcutaneous route. TNF-alpha inhibitors, it works by blocking TNF-alpha from binding to its receptors, thus suppressing the immune response. It reduces the pro-inflammatory cytokines, chemokines, and adhesion molecules, and they suppress the development of TH1 and TH17 cells. Etanercept, it is given at a dose of 25 mg per week, starting from day 1 of the menstrual cycle till 12 weeks of conception. The second one is adalimumab. 1 dose of 40 mg was injected 4 to 5 days before embryo transfer, and it is repeated every 2 weeks until 8 to 12 weeks of gestation. Both can be safely used during implantation and also during pregnancy. PBMC, LIT or PLI, the allogenic peripheral blood mononuclear cells or lymphocyte immunotherapy consist of collecting PBMC from the husband and injecting them intradermally with series of shallow injections in the forearm or thigh of the prospective mother and to prepare the immune system to tolerate embryo's antigens. After this injection, the couple is instructed to wait for 4 weeks before actively trying to get pregnant. But prior to this LIT, they have to undergo LAD test. LAD test is performed and the LAD test is negative, then only this therapy is allowed. It enhances the expression of anti-paternal cytotoxic antibodies in the mother, and progesterone-induced blocking factor, and reduction of TH1-TH2 ratio. It enhances the Treg cells and shift towards TH2 immunity in peripheral blood, which favors pregnancy. Intrauterine administration of PBMC, which is co-cultured with HCG for 48 hours, and it is instilled 3 days prior to ET. Intrauterine PRP is beneficial in patients with RAF and thin endometrium. PRP is autologous conditioned plasma, is a protein concentrate with anti-inflammatory and pro-regenerative properties. And this concentrate, it contains, the platelet concentration is around 1.5 to 4.5 lakhs per microliter. It is given at a dose of 0.5 to 1 ml, and it is instilled around the time of embryo transfer, usually 48 hours prior to embryo transfer. Intravenous lipid, administration of intralipid, that is, it is a parenteral fat emulsion containing soybean oil, glycerin, egg phospholipids, and MUFA in patients with RAF and RPL, where standard treatments have failed. Intralipid treatment was effective in patients with RAF or RPL with elevated TH1 cells in the endometrial biopsy. It is given as a solution of 4 ml intralipid at 20% dilution with 250 ml saline solution infusion. Few studies show 2-dose schedule. First dose on the day of oocyte retrieval and second dose 1 hour prior to ET. Multiple RCTs showed that intralipid administration significantly improved clinical pregnancy rate, ongoing pregnancy rate, and live birth rate, but no beneficial effect in miscarriages rate. Omega-3 fatty acid supplementation was used in patients with RPL and APLA syndrome. The rationale for using this, it reduces the formation of radicals and decreases the pro-inflammatory lipid products with a concomitant increase in resolvins, which in turn will modulate immune cells to a tolerogenic response. Omega-3 fatty acids also modulates the gut bacteria and production of metabolites, which in general reduces the pro-inflammatory states. But we need more clinical trials to determine the importance of this treatment in RPL and RAF. Low molecular weight heparin, here it is given at the dose of 0.6 mg per kilogram. It is a prophylactic dose and therapeutic dose is 0.9 milligram per kilogram. Most of the guidelines recommend heparin for treatment of APLA. Combining heparin and aspirin in pregnancy increases the live birth rate in women with persistent APLA and RPL when compared to aspirin alone. In inherited thrombophilias, like factor V Leiden mutation, low-dose aspirin alone was compared with low molecular weight heparin and aspirin and low molecular weight heparin alone, and it showed a comparable live birth rates. There was a recent study called ALIVE2 trial. It is a prospective randomized study, and here the patients with inherited thrombophilia and RPL did not find a difference in live birth rate between patients with low molecular weight heparin and in patients and in controls with no heparin. Low-dose aspirin and heparin are indicated for treating APLA. Aspirin alone induced a lower live birth rate than low molecular weight heparin and aspirin in patients with RPL or RAF with thrombophilia. Aspirin monotherapy cannot be considered for patients with RPL and RAF with autoimmune or thrombophilia component. Vitamin D therapy regulates the immune cell responses by inhibiting cytotoxic TH cells, TH1 cells, and TH17 cells, and promoting TH2 cells and Treg cells. Vitamin D deficiency is associated with miscarriage. Patients with RPL or RAF had associated vitamin D deficiency. The preconception treatment of vitamin D deficiency protects against pregnancy loss in women at a risk of miscarriage. In patients with RPL, the prevalence of APL antibodies, ANAs, anti-ssDNA, and T2 antibodies was significantly higher in patients with low vitamin D levels. Progesterone is an immunosuppressive hormone that regulates the NK cell activity and cytokine balance during trophoblastic invasion, and it leads to the expansion of uterine NK cells. Progesterone shifts the balance towards Th2 type immunity. It suppresses the generation of Th1 and Th17 cells and induces the Treg cell differentiation. A Cochrane meta-analysis demonstrated the benefit of progesterone for reducing the miscarriage risk. Many studies showed that vaginal micronized progesterone has increased live birth rates in women with history of recurrent miscarriages. Intrauterine HCG infusion. The use of HCG is still preliminary. A few studies mentioned that 5,000 international units of HCG was diluted with 10 cc of normal saline and 1 cc is infused, which constitutes to 500 international unit. It is infused on the day of OPU in case of fresh transfer or 3 days before frozen embryo transfer. In a prospective double-blind RCT, intrauterine HCG showed light but not significant improvement in the pregnancy rate. The last one is anti-obesity drugs to increase fertility. Obesity has been shown to have a negative impact on endometrial receptivity and it modifies the window of implantation. It has been postulated that the link between obesity and subclinical inflammation is responsible for RAF and RPL in obese women. Since metabolic changes like insulin resistance are associated with an array of immune and endocrine responses, the use of treatments to reduce obesity and insulin resistance may increase the fertility rates and reduce the incidence of RPL. Metformin, besides reducing the insulin resistance, also modulates the immune response and adipokine secretion. The GLP receptor agonist has been used recently for treating obesity, but we need further trials to determine the effectiveness before IV procedures. So here the corticosteroids are classified as level 1 treatment, hydroxychloroquine level 1 treatment, and calcineurin inhibitors are level 1, level 2. IVIGs are in level 1 treatment, and the rest are level 2, 3. Progesterone is level 1. The rest are level 2, level 3, and level 4. So this is the last slide for this presentation, and it is an ESHRE recommendation, and whatever we have mentioned has not been recommended by ESHRE except for vitamin D deficiency, and if it is diagnosed, it has to be treated. That's what ESHRE has mentioned. Thank you everyone for giving this opportunity.
Thank you very much, Kritika, and very, very sorry. It is, you have really taken a lot of pains to go through such a big article and then really, given a gist of everything about immunology. And this is the very, very hot topic nowadays because everybody thinks this is, if you can master immunology and if you can understand why sometimes pregnancies happen and sometimes they don't happen, if you can modulate something somewhere there and then you can achieve, that's the next big thing which can increase our pregnancy rates or success rates, basically. So that's what everybody is looking at, and a lot of people are already using LIT, tacrolimus and all that, but you have beautifully explained, like not everything works for everybody, and you just need to do these tests, and doing the tests is the difficult thing, I think, because doing the uterine NK cells and peripheral cells and all these cells, and then looking at which drugs will work for whom, and to determine that, I think we are probably going there, but still not there. It's not, nobody knows yet exactly like when to use what. And basically, I believe in progesterone. Progesterone is our savior, and it saves us a lot of times. Apart from that, I mean, personally, I don't use anything else apart from aspirin and steroids sometimes, and then LMWH. So these three will add to progesterone, but progesterone is the mainstay, in my personal opinion, and it will, if you can achieve your proper progesterone It should not be too high, it should not be too low, and it should be proper progesterone, support for your luteal phase. That will take care of a lot of this immunological factors and inflammation and a lot of things. I mean, that's my personal opinion. But I think this is a very nice article for all of us to go through 2-3 times so that we understand exactly what is going on, and then probably if you want to use other agents, then they can. Dr. Kundavi, you want to say something?
Yeah, that was a nice article actually, and I think it's a big hot topic coming. Everybody using thymosin and
Only thing is
tacrolimus a lot.
without understanding. It's like,
Understanding. So I even keep asking in the forum whether we have to do a test and then give all these medicines. But in one group they said you don't have to do this. There's another they said that you have to do a luteal immune profiling test or something before you start giving these medicines, or unless you have a Th1 Th2 ratio is altered, only then you give these medicines. But we give HCQ along with the rest of the medicines because we involve the rheumatologist, because it is very safe to have another person, who's really well versed in these drugs. So, and we've got quite a good pregnancies with the HCQ, like 200 milligram BD. Only thing is you'll have to make sure her ECG is okay and her LFT is fine. You do an ophthal testing before you give an HCQ. Only one patient had severe allergic reactions, then we have to stop. Luckily, after stopping, she did fall pregnant and then she even delivered recently. So other than the aspirin, heparin, we give intralipids and HCQ, steroids in certain cases. The patient herself becomes a control. In case she has got no pregnancy, we add these medicines. So HCQ study is still going on. So we might be publishing. So, I think, first of all, we should understand exactly the immunological, and then probably you can treat the patient.
everything like innate and all, adaptive immunity. So beautifully, this article explains so much. BK, it gives a lot of knowledge. Yeah, Kundavi, you were saying something. Sorry, I came in.
That's what I'm saying. We have to understand first before we start treating these patients.
Yeah.
And thank you, Kritika. She's brought in so well
Thank
all
you,
the
ma'am.
drugs and everything. Yeah.
It's actually a very large article. She studied patiently and then literally compiled everything. Anyone else wants to comment? Is Pramya there?
And these tests are also very expensive.
And they have to be standardized, like I think like AMH, initially we were doing AMH, but we know that we cannot depend on that several years back. Now it has been standardized. I think these tests over a period of time, maybe they'll get standardized. Now it is still in the beginning stage and everybody is thinking what to do, what not to do, kind of. Yeah, Pramya.
Ma'am, hello.
Yeah, Pramya. Yeah.
Yes, ma'am. Actually, there is a lot of thymosin usage, and most of the times it is considered as a prophylactic usage, actually. So, I think we have still not got a very clear conclusion, like, should we be doing a test, like, when, how, like, what is the test to be taken, what to be taken into considerations? Because recently I had seen a patient from Bangalore, like, even before the first IVF itself, HLA matching report has been done, actually. Only thing is, like, she has got regular cycles, no obvious, it was looking like an unexplained infertility. She had 2 miscarriages, one was a natural conception and the second one was like a IUI conception. It was a miscarriage. So APLA screening was done, I think karyotype was done, the rest of the stuffs, but directly there was HLA matching done, and that HLA match was given as like almost she was matching nearly close, like 9 out of 12 for especially the C gene. But after that stimulation was done, before stimulation itself, the LIT therapy was being given, because from the husband's plasma they have prepared and they have given 3 injections and they have stimulated the patient. And then like she had some 7 or 8 embryos, but it was transferred, it was negative. So there are too many investigations being carried out without any rationale.
Yeah, to achieve 100%. serious flow.
Yeah, but I don't know, like somehow we did a cycle once again without taking anything into consideration, just focusing on this thing. But there was a very gross culture problem because she had only made 3 embryos out of like 20 oocytes retrieved and 17 fertilized, and none cultured to day 5. There was almost 15 embryos were cultured to day 5. Day 5 embryos were 0. So I don't know whether there is any significance in the role of this immunology, this HLA matching in this culturing and everything and all. But there are some few genetic labs which are coming up and saying, like, even with the formation of the blast, from the blastocyst, they'll take a CG match and they'll correlate, and then they'll try to give an elimination or considering of the third party reproductions. So I think immunology has still been into innovations. That's what my knowledge and understanding is, as far as I have understood. I think Dr. Kritika has done a wonderful job. She made it very clear.
Thank you, ma'am.
Somebody is talking. Hello. Hello. If somebody wants to talk. Can't hear.
We can't hear you, ma'am. Can you please type it in the chat box if you want to ask something? Maybe they're not speaking to us, ma'am. Not sure.
Okay, fine. So we had a nice
Yes, ma'am.
day again. Thanks, Sindhu. And
Thank you, ma'am. Thank you, Vani, ma'am, for accepting as soon as we asked, and for bringing the entire team and all of you for actively participating. Thank you very much. Thank you, Vani, ma'am. Thank you, Kritika, ma'am. Thank you, Pramya, ma'am. Thank you, Madhumita, ma'am. Kundevi, ma'am. Thank you, ma'am, for joining. And thanks to Shield Connect for helping us with the Zoom platform and coordinating the meeting. Kundevi, ma'am, can we close the session?
Thank you.